So with all your permission, sir, we are getting started now.
Yes, please.
So may I have your attention, esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good morning and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this online event, jointly hosted by Indian Association of Cardiovascular Thoracic Surgeons, Indian College of Anaesthesiologists, Karnataka chapter of IACTA, Global Intensive Care Symposium, International Society of Cardiac Ultrasound, and Global Heart Care Foundation, USA. Now, the focus of today's session is ultrasound guidance for tracheostomy. Well, to start with today's session, I would like to present before you a short welcome video.
Good morning and welcome to the Sunday TE Critical Care Echocardiography sessions being conducted under the auspices of Indian Association of Cardiothoracic Surgeons, Indian College of Anaesthesiology, International Society for Cardiac Ultrasound, Global Heart Care Foundation, Global Intensive Care Symposium, and the Karnataka chapter of IACTA. Thank you for joining us, and with great delight, I welcome you to this Sunday breakfast session. Today we have eminent faculty from Bangalore, Dr. Venkatesh Gupta and Dr. Ratan Gupta, who will be taking us through this topic entitled ultrasonography for tracheostomy. It's a very commonly performed invasive procedure in intensive care units for patients who need prolonged ventilation and other indications. And please post your comments or questions in the chat box. We'll address it at the end of the session. And if you want to unmute yourself and speak into the mic at the end of the session, you may please do so if you're on the faculty link. And thank you so much for joining. With this, I would request Dr. Ratan Gupta to take over and do the meeting. Dr. Ratan Gupta is a senior consultant in cardiac critical care working at Narayana Institute of Cardiac Sciences. He's a very accomplished and experienced intensivist taking care of cardiac patients. With this, I would like to request Dr. Ratan Gupta to start the symposium. Thank you so much.
Good morning. Thank you, Dr. Murli, for the kind opportunity. Now I would introduce Dr. Venkatesh Gupta. He's a dear friend and previous colleague at Narayana Institute of Cardiac Sciences. And now currently he's working at Astor Whitefield as a consultant in the intensive care. He has done his IDCC, FICCM and EDICT. He will be speaking on use of ultrasound in tracheostomies. I invite Dr. Venkatesh Gupta to go ahead with this presentation.
Thank you, Ratan sir, for the kind introduction. Thank you, Muralidhar sir, for the opportunity. Thank you all for joining the morning session on Sunday. So I hope you'll be carrying certain important message. I will be sharing my PowerPoint. Are you able to see?
Yeah, it's visible, Venkatesh. Go ahead.
So I'll be talking about ultrasound guided percutaneous tracheostomy today in the next few minutes. So in the ICU, it is very easy for us to do it percutaneous rather than the open technique for various reasons. Whether it is planning, the safety, the cost effectiveness, everything when you put together, including the studies, all have shown that it is safe and cost effective to perform percutaneous tracheostomy in the ICU. Nowadays, open tracheostomies have reduced. The numbers have come down significantly only in case where there is anatomical difficulty of the neck or obesity or there is problem with the length of the neck. But we will see how even in obesity, our ultrasound helps. So percutaneous techniques are generally guided by anatomical landmarks or bronchoscopy. There is used by a few of the people who do it. And when it comes to anatomical landmark, it is sort of a blind technique and do not predict the presence of any anatomical variations, especially any aberrant blood vessels with a different anatomy. So it limits the safety margins during the puncture and dilatation. So using bronchoscopy or ultrasound is nowadays more advisable. And using bronchoscopy or ultrasound has increased the likelihood of successful puncture on the first attempt. And the procedure is quite simplified and it significantly reduces the complications compared to anatomical landmark guided percutaneous tracheostomy. So one study which compared traditional landmark versus ultrasound guided tracheal puncture during percutaneous dilatational tracheostomy. It is a randomized control trial and which showed that the real-time accurate tracheal puncture and the mean deviation from the midline was quite less, 15 degree plus or minus 3 degree when compared to the traditional landmark method where the deviation was quite huge statistically. The success rate was quite good, 87% in the ultrasound group, whereas it was 58% in the landmark group, which was also significant. The observed decrease in the procedural complication was not stated and significantly improved the first pass puncture. And the complications were very few, which was not statistically significant. And you may all be aware it's essentially used for percutaneous tracheostomy. The advantages are direct visualization, and while you are positioning the tracheostomy tube, you'll be able to see. So hence by it reduces the risk of accidental injury to the surrounding structures. And even in bronchoscopy gives good guidance for complex cases, especially difficult anatomy or prior neck surgery patients. It also avoids injury to the posterior wall of the trachea. Coming to disadvantages of the bronchoscopic guidance, you are unable to assess any of the anterior neck anatomy. When you are doing it, there is significant reduction in the minute volume where Your ventilator will be alarming continuously. You may have to increase the respiratory rate so that you maintain minute ventilation. CO2 can go up. There are some rare risk of pulmonary barotrauma or pneumothorax. Especially in patients with acute brain injury, we are more worried about acute elevation of ICP. And it also requires availability of good equipment, bronchoscopy, the staff to help you in the head end. You need some people who are experienced in handling. And so you need more people, more manpower. And it may also increase the procedure time because you may have to set up, introduce all the bronchoscopy, stabilize. So it may be slightly more time consuming, but now studies have shown that it is, again, not very significant, but slightly more time. But which one is better, bronchoscopy versus ultrasound guidance? So far, there is no study which has, determined the superiority of one over the other. It again depends on the unit to unit and your expertise. So there are few studies again which have compared bronchoscopy guided versus ultrasound guidance. This is one such study, real-time ultrasound guided percutaneous tracheostomy. Is it a better option than bronchoscopic guided procedure? This study clearly demonstrated that real-time ultrasound guided percutaneous guided percutaneous tracheostomy with a lower complication rate helps us understanding the cervical anatomy, vasculature, and hence the way you choose the puncture site can be modified. Similar, another study, a randomized non-inferiority control trial called the TRACKERS trial, which compared ultrasound-guided percutaneous tracheostomy to bronchoscopic-guided percutaneous dilatational tracheostomy, which again showed that ultrasound-guided percutaneous dilatational tracheostomy is non-inferior to bronchoscopic-guided percutaneous tracheostomy. Another study which clearly showed that you don't even need bronchoscopy to confirm the position. Ultrasound guided tracheostomy is equally safe and sufficient. So more and more nowadays, ultrasound is being utilized to guide tracheostomy. Last several years, we have never used bronchoscopy for percutaneous tracheostomy. We always succeeded in utilizing ultrasound, and more you use, the more easy it becomes, the more fast it is. So it is safe, rapid, repeatable, where performs well both in the simulated environment and clinical practice. Requires fewer personnel to perform, can master the technique with practice. So today, when I was preparing the talk, this talk I had prepared it long back, but now I again, when I was searching the literature, I found a nice article, ultrasound guided percutaneous tracheostomy, a risk-based protocol. So I found nice, interesting pictures and the steps which I'll be taking you through. But you may feel that whether it is so much of risk is there, but tracheostomy is always avoiding complications, and handling complication is one thing which is very important, but avoiding complications, for which we should know the potential complications and what all we should avoid. So this risk-based protocol is probably a good one. I have provided the links in the end. You can definitely refer to two important such articles which will help you to understand more. So complications associated with percutaneous tracheostomy is basically based on the anatomical structure. So whether it is tracheal laceration, paratracheal position, which is very important for us, esophageal laceration, pneumothorax, carotid artery or internal jugular vein injury, paratracheal vessel injury, pretracheal vessel injury, and innominate artery injury. If we keep these things in mind, then probably we can avoid all the potential complications. So the same important phases and 12 steps, which again we need not by heart if we are practicing it, but becomes very easy if we can, remember these steps. So the planning phase is essentially to identify the risk factors for complications and try to establish a safety margin. We will see how to do those things. Then the puncture phase, where you minimize injury to the adjacent structures and ensure proper cannula placement. In the screening phase, where you identify any complications that may arise after the procedure. We will go through each step in a little bit of detail. Before this, we should ensure there is no relative contraindication such as anatomical abnormalities, coagulopathy. We generally avoid doing procedures if the platelet less than 50,000, INR more than 1.5, APTT more than 2 times, intracranial hypertension, shock, patient in shock, severe hypoxemia, infections at the puncture site. So these are all again relative contraindication. You should always weigh the benefits with every case at that point of time. We should explain the risks and obtain informed consent. These are all mandatory steps. Having a checklist always helps so that you don't struggle in the neck of the moment where something is missing. So we always position the patient first. Preliminary examination will be conducted with ultrasound. Before that, you may have to sedate and paralyze the patient, adequate sedation and paralysis. Patient will be in supine position, the neck extended with a roll between the shoulders. We have the habit of keeping a firm pillow below the shoulder and place the soft ring below the head. So the head should be resting on a pillow, then slightly hyperextended. A linear probe is what is mostly required for us. The 6 to 12 hertz linear probe, the vascular probe, and the sector transducer, the cardiac probe, is also required at some. I'll tell you what is the utility of that. Most of the times we will be using the B mode and color Doppler. So the first step is identifying the course of the innominate artery. To be frank, we were also not used to check this, but this article is making me think that this I should also be doing next time. So what we do is take the same linear probe, put it in the transverse direction on the suprasternal notch and recognize the structures, the sternum, sternoclavicular joint and the pleural line. If you are not understanding this, it is still okay. You don't have to worry too much. Then you put the color Doppler and see for any vessel signal. You have to find the probe from caudal to cephalic direction to see if you are finding any Doppler signal. You can also use the cardiac probe, that is the sector transducer. We call similar location, suprasternal notch. You put the probe and put the color Doppler. If you see this kind of bifurcation of the innominate artery, then very likely that there is innominate artery which is moving across the trachea, in front of the trachea, and literature says that up to 66% of the normal individuals can have this kind of high rise innominate artery. But if the level is quite higher up, it is better to avoid performing percutaneous tracheostomy and better to send the patient for surgical tracheostomy. The next important thing is identify the pretracheal structures. The most important thing is you put the probe so you are using out of the plane, that is the transverse direction. You use the linear array probe, 10 to the 5 to 10 megahertz linear array probe, put it in the maximal resolution. The depth of the image is adjusted to keep the trachea just within the screen. Make sure that the trachea is in the center of the screen. So what you are seeing here, try to appreciate all the structures, the thyroid gland, the isthmus. This hypoechoic area is the tracheal cartilage. This is the air mucosal interface. This is comet tail artifact similar to what we see in the lung. That is essentially the reverberation artifact what you see at the equidistance. This is the posterior area of the trachea, roughly. This is again the thyroid gland. So try to appreciate all the structures. So this is again the thyroid lobe, the thyroid isthmus here, and try to appreciate the pretracheal vessels by putting the Doppler. You should not put too much of pressure on the probe. You put a gentle pressure so that the vessels are not compressed and you miss them see. Most pretracheal vessels are what? Veins or arteries. And most of the pretracheal vessels are small diameter and do not increase the risk of bleeding. But what is important for us is if try to measure the diameter. If the diameter is more than 3.9 millimeter, then probably whether it is vein or artery, then it is probably better to send the patient for open tracheostomy because of the risk of bleeding. So this is another similar diagram where you can see the trachea, thyroid gland, both the sides, and this is the isthmus. You can see that there are blood vessels on either side, but nothing in the midline. So it is still safe to go ahead and perform the procedure. So this is image which we recently captured 2 or 3 days back in our unit, where we plan to perform the cutaneous tracheostomy. And we could see a lot of vessels here, one here, one here, and one here. And the Doppler was also suggestive. So it is right across the midline. And this was more than sort of 4 millimeter. And even on the skin, we could visualize good amount of veins. So we had to shelve this procedure, and it was extending from top to bottom. So we step is identify lateral safety margins. So likewise, you put the probe, you try to see try to appreciate the lateral structures. This is the trachea, half of the trachea which you are seeing on the right side. So try to appreciate the anatomy and blood vessels. What is important for us is, you know, the distance from where the blood vessels are, centimeter from the midline till the major blood vessels, up to 2 centimeter is considered as safe margin. If it is less than that, then there will be risk of injury to the vessels. Common carotid artery is located less than 10.5 millimeter away from the tracheal rings. So we have to be extremely careful in such a scenario. The risk of injury to the blood vessel increases. Next, step 4 is identify the cricoid cartilage. What you do is you start sliding the probe from the first. You try to identify the thyroid cartilage, hyoid bone. From hyoid bone onwards, you can come down in a linear fashion. So you reach the cricoid cartilage. Cricoid cartilage is, this is how the cricoid cartilage looks. The bigger hypoechoic area, I'll show you here. This is a bigger hypoechoic area, little broader, Once you identify that, you slowly slide your probe downwards in the caudal direction. This is the smaller hypoechoic area, the first tracheal cartilage. This is the area between the first and second tracheal cartilage. That is where you stop and consider doing the procedure. That is how you slide your probe from above downwards. So identifying cricoid cartilage is very important, so that in case if you lose access to the airway, you may consider tricothyroidotomy. So you try to appreciate the cricothyroid membrane also. Okay, membrane access in case if you lose any important airway control. Next is measure the pretracheal distance and the distance to the midpoint of the trachea. So this is at the skin level in the transverse axis of the probe, and you freeze the screen and you try to measure the distance from here till the trachea. So this distance, the pre-tracheal distance is what we call pre-tracheal distance. It is helpful for selecting the cannula size in obese patients. There are different types of tracheostomy tube. The distal end may be larger or the proximal end may be larger. If the pretracheal distance is huge, then you may consider, little lengthier tube. And another important measurement which you have to calculate is from the skin to the midpoint of the trachea, a rough estimation, which helps to understand the margin of the needle insertion to avoid posterior wall perforation. So you know how much depth the needle should enter and beyond which it should not enter. Suppose this is 2 centimeter and this is coming up to 3 centimeter. So you make a rough marking on the needle. You should not cross beyond 3 centimeter. Okay. The moment you finish entering 2 centimeter, very likely that you are in the trachea. If you are not in the trachea, then you may have to withdraw. You can go, now that you know that the midpoint distance is around 3 centimeter, you can go up to 2.5 to 3 centimeter. If beyond that you are not able to aspirate the air, then you have to repeat the procedure. Come up to the skin. You don't have to come out the skin. Come up to the skin and reinsert the needle. You should not, direct the needle here and there. You should come out in a uh, linear manner. Step 6 is identify the longitudinal axis of the airway at the level of cricoid. This we always perform. Even before the transverse axis, you always screen it in the longitudinal axis. Try to appreciate the structures. The cricoid cartilage is slightly bigger hum, hypoechoic area. The tracheal rings are small bead-like structures, which you can always appreciate. This is the first. This is the space between the two cartilages. This is the second, and this is the third. This hyperechoic line is the line which arises because of reverberation between the mucosa and air surface. Then position the endotracheal tube. So you have to pull the tracheal tube out, endotracheal tube out, so that when you are entering, you are not neither damaging the tube or you are puncturing the cuff. So here, this is again the longitudinal axis. This is the cricoid cartilage. This is the thyroid cartilage. This is the cricoid cartilage, and this is the tracheal ring. So the double line, what you are seeing is the endotracheal tube. This is the cricoid cartilage again, thyroid cartilages. As this is while you are pulling the tube out under real-time ultrasound guidance. So you are continuously monitoring and pulling it under the ultrasound guidance. This is after pulling it out, the tip of the tube should be just above the cricoid cartilage, below the thyroid cartilage. This is the tip. How do you understand? A gentle jiggling of the tube millimeter wise, little bit to and fro, will make you understand that the tip is here. Or there is another way of checking it. So this is the double line which you are appreciating on the video. This is the video done by me. Sorry for the higher brightness, but the cricoid cartilage you are able to appreciate. This is the withdrawal of the ET tube. Again, under real time, you can see that the tube is being pulled out. If you want to see, I'll show you again. The tube is getting pulled out. You can see that. It's a short video. Another way to identify whether the tip of the tube is just above the cricoid is, once you make sure that you have adequately pulled out, what you do is put a color Doppler at that level, deflate the cuff first, then you start inflating the cuff with 5 cc of air. When the color Doppler is activated, you can see this kind of air flush test, because the air will be getting flushed through the soft tissue or whatever small amount of liquid in and around, which will give rise to this kind of air flush test. If it is not visualized, then likely that the tube is not pulled out adequately. So you may have to repeat all the steps again. So coming to the real-time puncture, as you screen in the longitudinal axis, you can make out where the cricoid cartilage is, where the first and second cartilage is, between the second and third cartilage. So your puncture can be anywhere from after the first cartilage to fifth cartilage, preferably between the first and second cartilage or second and third cartilage. So we should always make sure that the needle entry is not above the first cartilage. It should never be between the cricoid and first tracheal cartilage. If you have entered like that, you may have to come out and do it again. So you get a transverse longitudinal view. Then you can either rotate the probe wherever you identified second and third cartilage, rotate the probe 90 degrees, get it to the transverse position, or you start transverse axis view from the level of cricoid, slide your probe down to the first cartilage, then reach the second cartilage. Between the first and second cartilage you stop, or between the second and third cartilage you stop. That is the ideal position for the puncture. And you start entering with your needle. I'll show you the position. Try to go not beyond 75% of the measured pretracheal distance. Initially 75%. Then don't go beyond the midpoint distance, which you have already measured. So this is how the probe is held in your left hand. Make sure that you are supporting your left hand on the chin of the patient or somewhere, and you are entering the with your right hand. I always suggest to hold the needle hub rather than the syringe. We will get a better stability. So goal is to puncture the trachea in the midline. You have to follow the needle track. See, in the transverse axis, you will not be able to see the needle. You will be seeing only the needle track. Make sure that you follow the needle track by the soft tissue movement at its tip. We call interface a distinct acoustic shadow ahead of the needle as the needle enters. We'll see how it's seen. See, here are you able to see the needle? You will not be able to see the needle in the transverse view. So it is only the movement of the acoustic shadow. This is how it will be. So here, as you are entering, you will see some acoustic shadow, which is advancing slowly. Here it is again advancing. Here you should be capable of seeing the indentation of the soft tissue shadow on the trachea. That is how you track the path of the needle. So once you have entered, what we do is you stabilize the needle, introduce the guide wire, and get the needle out, stabilize the guide wire, and now you try to see the guide wire first in the transverse axis, and then you can see in the longitudinal axis also. First, you can give small, we don't not by, you first adequately sedate, paralyze the patient, give good position. You have screened already with your ultrasound. Then you have already positioned your probe in the transverse axis and you have entered the needle. Once the needle is inside, you can use it needle with, the cannula. You pull out the needle and through the cannula, you pass the guide wire, or you can use just the guide wire needle, no need of cannula. Pass the guide wire, get the needle out, stabilize the guide wire. But you should get the resistance approximately around 20-25 centimeter. You will get a resistance. The guide wire will not move forwards. If the guide wire is going entirely, then you should suspect something is wrong. Might have entered the trachea. So you should be very careful. Every step is very important. So you get the needle out, and once you screen it in the transverse axis, this is how you see the entry of the guide wire. You can see that it is exactly at the midline. Similarly here, the image is not very clear, but you can see in the longitudinal axis that the guide wire is entering, but we will see more images. This is how you scan it in the longitudinal axis. To rotate the probe into the transverse axis, I generally put it below the guide wire so that you can see the entry. And to stabilize the guide wire, you can always put the guide wire holder like this, which will be very helpful on the bedside. So this is the visualization of the guide wire in the longitudinal axis. You can see that it is entered. This is the cricoid, first one. Between second and third cartilage, the guide wire is entering. See the video again. The guide wire is entering between the second and third cartilaginous tracheal cartilages. Yeah. Now you are seeing it in the transverse axis. You can see that The guide wire is entering almost at 12 o'clock in the midline. You can get better images than this also. So identify, once that is done, then what you do is you put the dilator. Then you, once the dilator is adequately dilated, then you put the blue rhino, or if you are using a graded dilatation. Nowadays, nobody uses graded dilatation. You use the blue rhino technique, dilate adequately, get it out. Then you position the endotracheal tube. Once you position the endotracheal tube, you can confirm the tube cuff with the ultrasound. So that the cannula cuff is nothing but the tube cuff. Once you have inflated, you use the same linear probe in the transverse axis and try to visualize this kind of rounded hypoechoic image posterior to the tracheal rings. So identification of the cuff's position excludes the paratracheal position for the tracheostomy tube. So that is one more important step we can consider. The last but most important step is to rule out the pneumothorax. You don't have to wait for X-ray. However, you'll end up doing X-ray, but for various reasons. Even if you are doing it with ultrasound, you can just mention in your notes that pneumothorax is ruled out. You put the linear probe vertically or horizontally between the two ribs on either side of the chest. It's not one side of the chest. So this is between the two ribs. This is the pleural line. We should be capable of appreciating the slide of the pleural line. This is the absent lung sliding. If you put it like this, you should be able to appreciate the seashore sign. If it is not there, then the barcode sign intermittently coming, which is the lung point. If somebody has developed pneumothorax, this is how you see the lung point. This is a point where the lung is coming and touching the pleura because of the pneumothorax. You will be able to see the lung point. So these are the important key steps for the percutaneous tracheostomy with the use of ultrasound. So the take-home message is percutaneous tracheostomy has lower complication rate than the open surgical tracheostomies. Addition of fiber optic bronchoscopy has aided in more precise tracheostomy placement, but requires additional personnel. Bronchoscopically guided percutaneous tracheostomy has not been shown to decrease the complication rates. Real-time ultrasound guidance improves the accuracy of tracheal needle puncture, first pass success rate. Fewer procedural complications. Even there are studies where a 2-hour workshop on tracheal model has helped many trainees to get adequate skills to perform tracheostomy. It is also recommended that at least 20 procedures should be performed with the help of guidance before. Roughly around 20 procedure is the time of mastery that you need to acquire the skills. It is easy. We always do percutaneous tracheostomy on the bedside with the help of ultrasound. Very rarely we have used bronchoscopy. Probably in previous tracheostomies is where we have considered using bronchoscopic guidance. But otherwise, even in previous tracheostomy, if it is not complicated, then the redo cutaneous short neck patients, there are studies which have shown the benefits of ultrasound guided tracheostomy in all such population. Thank you. So
thank you, Venkatesh. That was a very lucid presentation. Your videos were very clear. We could appreciate not only the different cartilages, you could nicely demonstrate the guide wire entering, and one thing which was very impressive was the way you pulled out the endotracheal tube under guidance. So that was very clear. Generally, that is a big struggle.
yes, sir.
And I think the other thing which probably you need to mention is what is the role for the adult cardiac probe? You're mentioning only about the linear this thing. So I think you forgot to tell about the.
Yes, sir. Adult cardiac probe is only in this place where I'll show you the image where you are using where you are trying to find out the course of innominate artery.
Innominate, okay.
There also your linear transducer is sufficient. If it is not capable of picking, then only you use the cardiac probe, that is a sector transducer. Put it on the
Okay.
suprasternal notch, then try to put the Doppler, color Doppler and see. Then you have to fan your probe little bit superior and caudal. Then very likely that the innominate artery is high lying and you should be extremely careful and probably not do the percutaneous tracheostomy.
Yeah. I think I've been practicing the suprasternal view to
Correct,
check
sir.
on the arch and the
Yes,
major
sir.
vessels, but I
Yes,
have
sir.
never really thought about this context, context and
Yes,
tried
sir.
looking to avoid innominate. But I think
Yes,
the
sir.
way you have mentioned now, we'll have to be more careful.
Yes, sir.
So ultrasound is really useful when we are doing a percutaneous tracheostomy, and it gives you a lot of confidence. I have been regularly using it to rule out major vessels in the pretracheal field, and once you have decided you are in the center,
Yes, sir.
I do it offline. I don't do it real time, but I
Yes, sir.
think it might be worth trying doing real time.
Yes, sir.
Only thing is sometimes when you're holding the needle and the syringe with the air
Yes, sir.
and trying to coordinate it with the probe as well, that
Yes, sir.
becomes a little difficult. Maybe I think just
Yes, sir.
taking the needle under without the syringe, I think might help improving your this thing.
Sir, here what we can do is, sir, the hand-eye coordination is very important, as sir said. That is what we all have to master. So the left hand, when you are holding the probe, should be resting on the patient. Your left hand should be, the left hand which is holding the probe should be resting on the patient chin or on the neck, so that your left hand is not sliding. The frame of the window which you have acquired should be fixed, and it is always better to have 1 or 2 ml of saline in the syringe attached to the needle, but better to hold the needle hub. You will get a better stability. You will
Yeah, I think whenever I try to take
feel
air
the
and
loss of resistance very easily, unlike
yeah, yeah,
and another important step is the air. I mean, we always check that air coming into the syringe filled with the saline. One more important thing I wanted to tell, I just forgot. I tell, sir. And all the images, all the apart from the article images, whatever videos, they're all really acquired by me bedside. So we practice it real-time ultrasound, and it's quite helpful, sir.
okay. Uh, I think quite a few people in my center also are trying to do it real time.
Yes.
I think I'll have to get better at doing that as well. But we are using ultrasound for all our tracheostomy patients. We definitely try to rule out major vessels, and uh, sometimes we do have difficulty with anatomical landmark technique. You go to the side. So
Yes, sir.
once we use ultrasound, the first pass success definitely goes up. There's one
Yes, sir.
question in the chat box.
Yes,
Dr.
sir.
Abhay Prakash is asking, can you repeat the step 9 and 10?
Yes.
Can you do that, Kankish?
Yeah. So basically, what is happening is that step 9 is real-time puncture. So basically, real-time is nothing but you are continuously observing what you are doing on the ultrasound. One is ultrasound guidance is different. Real-time practice is different. Real-time practice is as you are watching, you will be entering the trachea. So what you do, first you position your probe longitudinally. This is a cricoid. This is the cricoid. This is the first tracheal cartilage, second ring, tracheal ring, third tracheal ring. This is what you noticed in the longitudinal view. Okay, you understood? Then what we generally do is I lift the probe out. I just first appreciate all these things. I see how many rings are visible, 4, 5, sometimes nicely visible. Then what I do is I rotate my probe into transverse direction and again start my screening from the top. Again, I go at the level of hyoid or tracheal cartilage. Tracheal cartilage is very easy to understand. Then you appreciate the cricoid cartilage like I have shown you in the previous thing. When you come and appreciate the first tracheal ring, then you stop at the second tracheal ring, or immediately after the second tracheal ring, you stop it. Okay, that is one way of doing it. In this, what is explained is, once you identify between the second and third space, you rotate 90 degrees, but the probe should be really stable and it should not move up and down, so that you understand. So the midpoint of the probe, the marker on the probe is the midpoint, really lies on the between the second and third cartilage for you to enter the needle. I suggest you always, what we practice is always, again, first you see it longitudinally, then again slide your probe from top to bottom. So the moment you finish the cricoid cartilage, appreciate the first tracheal ring. Immediately after the first tracheal ring, you stop. Or immediate, if you have 5 visible tracheal rings, after the second ring, you stop and stabilize your probe. If it is even little bit, tilted or misplaced, again you have to start from the beginning. You again identify the cricoid. Cricoid, if you are unable to identify now, you palpate the cricoid, put your probe on the cricoid. You should be able to appreciate. Then slide your probe down, stop immediately after the second ring or after the first ring. If the 5 rings are there, I stop at the second ring, immediately after the second ring. So this is the entry. That is where the midpoint you try to enter. I'll show you. This is where you stop it and you enter. I'll show you another image which helps you to understand. This one. See, the first image is the cricoid cartilage. This is how the larger hump of the cricoid cartilage is visible. The middle one is the first tracheal ring. Immediately after that, you stop. As you are sliding down, you stop it at that. That is the point of entry for you. That is the step 9. Coming to step 10. Step 10 is identify the path of the guide wire. So you entered, you identified the midline after in the step 9. Then you entered with your syringe. So you entered the predetermined distance. Say, for example, I said from skin to trachea is around 2 centimeter. Within 2.5 centimeter, you should be able to get the air. Okay, once you get the air bubbling into your, syringe filled with the water, you leave the probe, stabilize the needle, you pull out the syringe, put the guide wire inside the needle, push it as much as it goes. So you scan the wire with your probe. One is in the transverse view, this is in the longitudinal view. Transverse view, you try to see exactly whether it is between 12 and 1 position. 11 to 1 position is good. Any lateral, and repeat all your steps again. So this mid position of the guide wire is very important. Between 11 to 1 is acceptable, but if it is anywhere after 1 or before 11, you should remove it and do it again. This is in the longitudinal view. This is how you see in the longitudinal view where the guide wire is entering. This is in the longitudinal view again. The first one is cricoid cartilage. Next is the ring. See, I can see that guide wire is going between second and third tracheal rings. This is again in the transverse view, entering at the midpoint of the trachea. I think I explained 9 and 10.
Yeah, that is quite clear, Venkatesh. And there is one more question in the chat box. How about ergonomics? How do you position while performing the tracheostomy? What is the position of the operator, and where do you place the ultrasound machine, and where do your assistants stand?
So generally, make sure that the patient head is near the head end so that the patient, the person who is standing at the head end is also comfortable. Once you, and patient is preferably slightly towards the right of the bed. If you are a right-hander, naturally you will be standing on the right-hand side of the patient. And the ultrasound machine should be on the opposite side so that you are easily seeing the ultrasound machine. And we get a nice ultrasound sheet, probe sheet, which we always utilize that. These are all arthroscopic sheets, something like that. We have a nice sheet which you put it on the probe. And once you pull the tube out, what we do is we head end. Either if I don't have a trained person, I call a respiratory therapist to be on the head end. What I do is I pull the tube myself out with the help of ultrasound, or ask any other trainee or one of my colleague to pull the tube out with the help of ultrasound guidance. So I put the probe, and these are all before preparation of the patient, before draping. So I pull the tube out and ask somebody in the head end to hold the tube. To avoid problems, now what we do is we just tie the tube so that it becomes very easy. There is no air leak, and the hands are also relatively free, but yet one person is on the head end putting the fingers on the tube to have a stable position. So, and I put a big size pillow below the shoulders, and the head adequately extended, not hyper extended, adequately extended, and put a soft pillow below the head ring. The soft gel foam ring comes from that I prefer. Or your head ring also should work, which stabilizes the head. That is what we generally do to position the patient.
Yeah. Thanks for that, Krish. And I don't see any other questions on the chat box. What about the patients who are on ECMO, Venkatesh? When do you time your tracheostomy on those patients?
On ECMO, sir, generally we used to wait initially, but nowadays we are trying to do little early tracheostomy. Probably after 3 days or 5 days also we are considering doing it. Before and all, we tried even extubating them to see if they are tolerating. Sometimes they required HFNC, but moving ahead, few of them required re-intubation, so we stopped extubating them. Nowadays, we are considering early tracheostomy.
Yeah,
Maybe
I think
depending on
one of the
lung.
concerns always was the anticoagulation on ECMO. So
Yes,
how
sir.
do you manage your anticoagulation?
Anticoagulation, so again, sir, the guideline says that you stop it 4 hours before and check the APTT. And if it is adequate, if it is in the normal range, we can go ahead and do it. Two schools of thought. One in ECMO, better to do surgical tracheostomy. Few people prefer to do surgical tracheostomy because you achieve adequate hemostasis. Because we have seen even a small blood vessel can lead to catastrophic bleeding. So personally, I prefer, we have done both, sir, percutaneous also in few patients and surgical also in few patients. But if you ask me, surgical is probably better, sir. Two schools of thought, even some literature says surgical is better. Some literature says percutaneous is doable. But in our experience, we have done both, but surgical seems to be achieving better hemostasis so that you don't have any iota of doubt that any one blood vessel is bleeding.
Okay. I don't think there are any further questions on the chat box, Venkatesh. Yeah, that was a very nice and lucid presentation. I think hope it's very clear for all the delegates who are on the meeting. And
One question is there, sir. Size of tracheostomy tube somebody has asked.
yeah,
See, this is
okay,
one of the image I forgot to mention. When you are measuring the cricoid cartilage, at the level of cricoid cartilage, you can measure the internal diameter. Okay. This probably, this will give clues to choose size of the tracheostomy tube.
okay, all right. Yeah, I think nothing much to choose regarding the tube size in adult patients. Maybe
Yes, sir.
the pediatric patients, I think you'll have to be very careful. Adult male, generally we use 8, 8.5, and a female we generally take 7, 7.5.
Yes, sir.
And generally that is sufficient, but I think this guidance should help.
Yes, sir.
So
So one of the
I will,
contraindication is a pediatric age less than 14 is a contraindication for percutaneous tracheostomy in the literature. That's what it says.
okay, okay,
We all practice adult, no, sir.
okay.
So
I
One
think,
of the contraindication is age less than 50.
yeah, I think it's always risky, especially in a very small patient. But I think the intermediate group, sometimes if the trachea is well developed, we have managed to get in a 6 size or 7 size sometimes. And
Okay,
we
sir.
have been intermittently doing tracheostomy. Of late, I have not done a pediatric thing.
Okay, sir.
Thank you, Venkatesh. That was a very nice
Thank you, sir.
presentation. And thank you, Dr. Murli, for giving the opportunity. See you again, hoping to join again sometime. Thank you.
Yes, sir. Thank you, sir. Thank you all.
Yeah, bye.